Hello everyone, welcome back to my channel. Today we're discussing case 4 of the ITU series. If you've not checked out the previous case study, please do check out. Today we are discussing about seizures. Seizures are sudden abnormal activity within the brain, and this is due to synchronized firing of the neurons abnormally, and they can lead to the symptoms such as sensory symptoms, motor symptoms, psychic symptoms, or impaired consciousness, depending on which lobe is involved and what is the progression of the seizures. So why do seizures occur? So normally in the brain there are certain neurochemicals or neurotransmitters which maintain the equilibrium in the brain. So there is GABA and glutamate. We're discussing about seizures. So GABA is gamma aminobutyric acid, and that is inhibitory neurotransmitter, and the glutamate is the excitatory neurotransmitter. And when there is impairment of these two, that can lead to seizures. In sense, reduction of GABA and increase of glutamate can lead to seizures. Depending on what brain part is involved, this can be focal seizures or generalized seizures. So if focus of seizure is only from particular lobe of the brain, that is example a temporal lobe, then it is a focal seizure. But if the focus of seizure is generalized within the brain, that is for example cerebral cortex, then it is a generalized seizure. In focal seizure, again there is classification depending on the consciousness level. So in focal seizure, if there is preserved consciousness, it was called previously as simple partial seizure, or now it is called as focal seizure with preserved consciousness. And if in focal seizure there is impaired consciousness, then previously it was called complex partial seizure, and nowadays it is called as focal seizure with impaired consciousness. In the same way, in generalized seizures, there is generalized tonic-clonic seizure, which is previously called as grand mal seizure. We have absent seizures, which was previously called as petit mal seizures. You have atonic seizures, which is the sudden loss of the tone and the person drops down with seizure. That is atonic seizure. Then tonic seizures, which is increased in tone. There's clonic seizures, and then there is myoclonic seizures aspect. So in general, in generalized seizures, there is sort of a level of impaired consciousness. It could be prolonged consciousness in case of generalized tonic-clonic seizures, or it could be partial impaired consciousness, or impaired consciousness for a short duration in case of absent seizures and myoclonic seizures. So why do these seizures occur? We understood the electrophysiological changes occurring in the brain causing seizures, but what precipitates these electrophysiological changes? So the first most common cause of seizures would be electrolyte disturbances, especially sodium disturbances, calcium disturbances, and magnesium disturbances. Hyponatremia, hypocalcemia, and hypomagnesemia can cause seizures, and the brain is very susceptible to these electrolyte changes. The other most common thing is glucose, so hypoglycemia can lead to seizures. Apart from electrolyte imbalances, there could be some certain structural abnormalities within the brain leading to seizures. For example, a tumor causing seizures, scarring of the brain secondary to, say, traumatic brain injury causing seizures, anoxic brain injury, that is a brain injury secondary to loss of oxygen or impaired blood supply and oxygen. Then secondary to stroke causing gliosis again. Then certain AV malformations like a cavernoma can cause seizures. Then any bleed in the brain like subarachnoid hemorrhage or subdural hematoma can cause seizures. Apart from structural abnormalities, there could be other reasons like channelopathies, which is hereditary in nature, causing seizures. The other reason could be infections. So infections involving the brain like a tuberculoma or neurocysticercosis or say meningitis, encephalitis, these things can also cause seizures. How do we investigate for seizures now? So investigations are very simple in case of seizures. So first is the blood test to rule out the electrolyte disturbances, and then you can do imaging, which is a CT scan, MRI. So CT scan in case you're suspecting a bleed or a clot, and MRI in case you're suspecting a tumor and you need further investigation, delineating the cause. Then EEG. So EEG helps in determining the pattern of seizure. Based on the pattern of EEG finding, they can qualify seizures again. So before we move further, we have to classify or have a good concept of what a seizure is and what is an epilepsy. So seizure is an event. It's one particular event where there could be jerking of body, or there could be sensory impairment or conscious level. So any of this is classified as a seizure. Whereas epilepsy is a diagnosis. So epilepsy is a long-term problem. It is a proper diagnosis, and epilepsy is due to a structural or chemical impairment which makes the person prone to have seizures. So what do I mean by that? So if a person has hypoglycemia and they have seizure, that means they have seizure, but they don't have epilepsy, because it can be reversed and there is no underlying structural problem or biochemical problem causing this person to be prone to seizures. It is just a temporary problem. Uh, Another example could be hyponatremia. So if a patient has hyponatremia and they have seizures, they just have seizure. They don't have epilepsy. If a person has seizures and on investigation it was known that an MRI scan and it showed a tumor, then that would be epilepsy, because until this tumor is in this person's brain, they are more prone to seizures and they have epilepsy secondary to the tumor. So how do we manage seizures? First main thing to notice when a person is seizing is to protect their airway, because there could be aspiration. The patient could aspirate from their own secretions, or they might vomit and aspirate it. And they might have obstruction of the oral cavity, and they could have a tongue bite, which is leading to again bleeding, causing aspiration again. So in any case, your airway is your first key priority in case of seizure. You can help prevent further airway compromise by putting the patient in a recovery position, which is left lateral position. Then, if possible, if the patient is drowsy, you might think about airway adjuncts like oropharyngeal airway or nasopharyngeal airway. In seizures, oropharyngeal airway can be difficult because they have clenching of the jaw. So putting an oral airway is difficult, but you can go for nasopharyngeal airway in that case. You can always start them on 15 liters NRBM. Also look at the OPS, check for hypertension, check for the breathing pattern, and check for the SATS level when a person is actively seizing. So start a timer to see how long is the seizure lasting for. If the seizure lasts for about 1 to 2 minutes and it self subsides, then you don't have to treat it. But then if you see that the seizure is actively going on and it's not subsiding, then you will jump in to treat it. The first line of treatment would be benzodiazepine, and the most common drug we use is lorazepam. So IV lorazepam, if the IV axis is present, and you can give up to 4 milligram of IV lorazepam. If you think because of lorazepam or because of the post-ictal period, the consciousness is reduced, then again you can put in an airway. And in this case, you can also put in a definitive airway like an igel, and then bag and ventilate them while you have senior help. After you give the benzodiazepine, if they still continue to seize for 5 minutes, then the patient has landed in status epilepticus. So status epilepticus is another term wherein there's ongoing seizure for more than 5 minutes, more than equal to 5 minutes, and then there are 2 seizures back to back, and between the seizure period there was no recovery. Then we classify them as status epilepticus. So what happens in status epilepticus electrophysiologically again is that the brain usually, as we told about the balance between the glutamate and the GABA neurotransmitters, initially the glutamate neurotransmitter is increased, and that's why the seizure has happened. And the GABA is trying to compensate. The brain tries to compensate by increasing GABA levels. And when we give benzodiazepines, this further increases the GABA level and tries to subside the glutamate. After a certain period of time, and in this case, when you're talking about status, this is when the GABA receptors are engulfed, they're not on the surface of the neurons, and even though you give benzodiazepines further, the receptors are not available, so there is no point in giving them lorazepam furthermore. So usually they give 4 milligram of lorazepam. They try to give another 4, but after that, there is no point in giving benzodiazepines anymore, because it becomes refractory to benzodiazepines. So at this point, you would have to load them with an anti-epileptic drug, and usually we give levetiracetam because it's quite safe. It has less side effects compared to other drugs. If the patient does not recover from seizures in spite of giving the levetiracetam, then it qualifies as a refractory seizures. So refractory seizure is benzodiazepine with anti-epileptic drug loading, in this case levetiracetam loading, still they continue to seize, then it is refractory status epilepticus, because it's refractory to the drug which we've given in addition to benzo. In that case, you would need senior help, and especially the anesthetic help, to sedate the patient. And because you want to sedate them with IV propofol or IV midazolam, you would want to take care of the airway, that is, intubate the patient as well. And when you start intubating them and sedating them with the IV medications, you would add another anti-epileptic drug, most likely IV sodium valproate, and then see if this patient is further seizing. So in spite of sedation, you can see active seizures when you monitor the patient, or you would want to do EEG to find out if there is ongoing epileptiform activity within the brain. If they still have seizures ongoing for more than 24 hours in spite of being on IV sedation and having anti-epileptic drugs, then this is known to be as super-refractory status epilepticus. And you would need neurology input to further think about other medication which could tackle the seizures. So how does this anti-epileptic drug works? So remember the sodium channels, calcium channels, and glutamate we are talking about. So certain medication, like in case of levetiracetam, act on the glutamate to reduce inhibit the glutamate action, and certain medication work on the sodium channels. So they inhibit the sodium channels, which in turn help in the glutamate release or excitation of the neuron. So sodium valproate and phenytoin inhibit the sodium channels. Phenytoin also acts by inhibiting the glutamate receptors. And then in case of certain drugs, they inhibit the calcium channels, like for example ethoxyzumide. Depending on the whether it is focal seizures or generalized seizures, there are certain drugs, anti-epileptic drugs, which are preferred over the others. So at what point do we think about a specific drug? When you see a patient seizing actively, you don't think about what kind of seizure it is and what kind of anti-epileptic drug can I give this patient. You give them benzos, you give them loading dose of anti-epileptic, which is levetiracetam, and you go on further to see if it is status or refractory. That's your urgent management. But once the patient finishes the seizure episode, when you are doing a workup of this patient, and you want them to be on long-term medication, that is when these anti-epileptic drugs specific to the type of seizure come into picture. If it is a focal seizure, then carbamazepine is preferred, and this acts by inhibiting the sodium channels. When you think about generalized seizure, like generalized tonic-clonic seizures, levetiracetam is the most common use. You can also use sodium valproate. In case of absent seizures, then it is ethoxyzumide, because absent seizures are usually in children where thalamus is involved here. There is thalamocortical pathway, and thalamus is very rich in neurons and it keeps firing and it inhibits the cortex, so there is impaired consciousness as well. A certain calcium channel in this thalamus is inhibited by the specific ethoxyzumide. In case of pregnant women, instead of sodium valproate or phenytoin, lamotrigine is preferred because it's more safer in pregnancy.